We are going to go ahead and get started. Mic okay at this distance? We good? Are we ready? All right. Well, welcome everybody to the session on the intersection of housing and health. We are so happy to have you all here in this room. I am Allison Balmas-John. I see many familiar faces. I'm the Population Health Manager at the Rappahannock Area Health District. We have a great panel of speakers for you this morning, ready to talk about this issue and the multitude of ways that housing impacts our health. I am especially excited to be here because affordable housing was identified as one of our priority issues in the Community Health Improvement Plan, which we completed last year in partnership with Mary Washington Healthcare. I see Xavier up here at the front, as well as many other organizations. And affordable housing was a little bit of a different issue for us to be getting into. I will be honest that I think us, as well as Mary Washington, were a little shell-shocked when we saw that did come to the forefront when we heard from the community about the top issues they wanted to see addressed. But a lot of our data really pointed to affordable housing as a key issue. I know we've already heard a lot of data points this morning. We, in our analysis, saw that Virginia as a whole has eviction rates that are more than double the eviction rates of the US. And in Spotsylvania, that eviction rate is even higher. We saw that 31.7% of Fredericksburg residents are experiencing a high housing cost burden. We saw that several of our localities have higher rates in the state of substandard housing. But I think most importantly, of the 20,000 community residents that we talked to through our survey, 46% identified affordable housing as the number one response to the question, what would most improve quality of life in our area? So really powerful to hear from over 900 people that was the issue that they wanted to see addressed. So I won't go into that data any further. If you are curious to hear more about the Community Health Assessment or Community Health Improvement Plan, feel free to come to the Rappahannock Area Health District table. And we have copies there and can answer any questions. But I will kind of close this out and we'll go into our panelists. That when most people are thinking about attainable or affordable housing, I don't think that health outcomes are the first thing that they're thinking of. So just like we weren't necessarily thinking about affordable housing as the health issue we thought we'd be addressing, I don't think that when people are thinking about affordable housing, health is instantly what they're thinking about. But what we've seen, time and time again, is that these are really intricately intertwined issues, and so I hope that that's what we're able to hear more about today, and we welcome any questions about that intersection of those two issues. So without further ado, I'm going to pass it over to Ellen, who's going to introduce our first panelist while I get the slides all queued up.
Good morning. Can everybody hear me? Hi, my name is Ellen Justison. I'm the Community Engagement Specialist with Rappahannock Area Health District, and I'll be introducing our great panelists this morning. So we're going to start off to my left with Ms. Sandra Serna. She is a public health professional with 15 years experience working with local, regional, state, and national leaders across a variety of sectors to ensure all communities can become healthier places to live, learn, work, and play. Ms. Serna currently leads the Office of Health Equity at the Virginia Department of Health, where she oversees the divisions of primary care and rural health, social epidemiology, multicultural health, and community engagement. VDH's nationally recognized Healthcare Workforce Incentive Unit and partners and Prayers and Prevention Program are also within her jurisdiction. Moving over, we have Dr. Steiner with Fredericksburg Christian Health Center. He is a family physician and CEO of the Fredericksburg Christian Health Center, a nonprofit ministry providing charity care to the poor. The Fredericksburg Christian Health Center collaborates with community partners to meet the healthcare needs of some of the most vulnerable in our community who find the traditional healthcare system to be inaccessible, including those who are unhoused. Dr. Steiner and his team have partnered with Micah Ministries in a way that facilitates weekly physician visits with unhoused neighbors at Micah facilities and house calls. This Health Bridge program brings primary care and care coordination to a group of people who frequently neglect their health as a result of housing and shelter instability. And then finally, we have Teresa Bowers. She is an occupational therapist with over 37 years experience, specializing in the fields of behavioral health and geriatrics. She has practiced for over 29 years in the home health setting. In addition, she has served for 14 years as the director of the Seniors Visitors Program at Mental Health America Fredericksburg, a volunteer based visitation program for the lonely, isolated senior citizens. She is a clinical faculty at the Virginia Commonwealth University in the Department of Occupational Therapy. And currently, she is the Health Innovation Navigator and Healthcare Coordinator for Micah Ministries, a collaboration of churches working together under one nonprofit umbrella to cultivate community and care for the homeless neighbors in the Fredericksburg community.
So good morning, everyone. It's an honor to be here, and I'm delighted to talk about the intersection of housing and health. Prior to coming to the Virginia Department of Health, I was the Vice President of Health and Housing at a nonprofit policy collaborative in Washington, D.C. of nonprofit affordable housing providers across the nation. Some of the largest, some familiar names you may know, like Volunteers of America, Mercy Housing, and many others. So this is an area that is near and dear to my heart and is key to health equity. Let's see. Okay. So, why health and housing? Well, place has a tremendous impact on our outcomes and the resources that individuals can access. In fact, and I believe it would, the Robert Wood Johnson Foundation, the premier public health foundation of the United States, as well as prior to that, the California Endowment, did a lot of work in this space over the past several, 10, 15 years, and coined the phrase, in essence, that your zip code has much more of an impact on your health outcomes and your life expectancy than your genetic code. And so it's really, that intersection of nature and nurture. And one of the seminal writings or summaries of the research on the intersection of health and housing came out in the Journal of Health Affairs in June of 2018. It was a comprehensive literature review looking at everything. And essentially what they came up with was there are 4 distinct pathways or buckets that health and housing influence. There's a bidirectional way in terms of, relationship between health outcomes and healthcare costs. So in the category of stability, that would be, we understand that folks who are unstably housed or have gone several years, with unstable housing, they tend to have a higher risk of having poor health outcomes, right? It's a lot harder to take care of your health and well-being, just the wear and tear of surviving on the street. When we think of quality and safety, that's more of those environmental factors. So is there lead in the paint? Is the paint chipping? Are there young children in said home? Does the home have mold? Does it have asbestos? Does it have other factors that can trigger asthma, which is a preventable condition, and quite frankly, a condition that we see, if untreated, we see a lot of visits to the ER, and that could be prevented, and that costs money. When we talk about affordability, if you are paying too much for your rent or mortgage, that means that there is less disposable income for other needs. So what that may look like is, you have a nagging pain in your stomach or a mole on your arm that's growing, and you just tend to, you don't have the resources necessarily to go seek primary care or go seek care when it doesn't seem to be that big of an issue. Also, don't forget, there was a comment in the plenary this morning in the discussion about those types of jobs, especially I'm thinking service industry jobs, where if you're not getting, you don't have necessarily the paid PTO or sick time to take off. So if you are taking time off to attend to an issue that may or may not be something severe down the road. You're not sure, but that means if I miss work, I'm missing wages, right? And I'm missing providing for my family. And then finally, just neighborhood. Walkability, access to jobs, access to community amenities, good schools. How far is it to travel? I'm, on the side involved in local public transportation advocacy efforts as a private citizen of Richmond, Virginia. And, there's going to be an awesome new Lego factory that they're going to put in the Chesterfield area with absolutely no access to public transportation yet, right? So that's something to consider. It eliminates the opportunities for a wide variety of Virginians who don't have private vehicle access to potentially seek jobs there. So when we talk about the role of public health institutions and advocates, the role is shifting. Have any of you seen this graphic before? Yeah. Good, excellent, I'm glad. So maybe a couple of people, I see some nodding, and this really indicates the range, the continuum of public health services and interventions. And I would say traditional public health and healthcare in some regards, tends to be sometimes more on what is to your right. So we're concerned about, mortality and disease and injury prevention, focused a lot on behaviors. We need people to exercise and eat right. But as I talked about earlier, in terms of your zip code having more of an influence on your health outcomes than oftentimes your genetic code, it's really the living conditions, those items on the left, where we have the opportunity to collaborate with other sectors and have a lot of impact. I think, and I want to commend, Mary Washington Hospital System and Rappahannock Health District for, you got the results from the community. You heard from the community, and they said housing is a major need. And that takes bravery, because it is not in your wheelhouse. And, I'll say that when prior to getting into housing, I worked for a public health institute down in New Orleans, Louisiana, and we were hired to conduct community health needs assessment for nonprofit hospitals around the Gulf Coast region. And, some hospital leaders were like, yes, we want a survey, we want focus groups, we want all that, we want to hear what the community says. And what they said, and based on that, prioritized what they could do and came up with a plan. And quite frankly, we also had clients who did all of that, paid for all of that qualitative data, and at the end of the day decided on the priorities that were theirs already in their head. I think it takes a real commitment and bravery to say, okay, we're going to do this. And that can look very differently depending on what your sector is, but there is a place for you. So as far as the Virginia Department of Health and how that concerns us, similar to what was found in Rappahannock Health District, when the team, it's not my office, but we collaborate with them a lot. It's the Center for Community Health Improvement at VDH, and they put together the 2023-2027 State Health Improvement Plan. One of the 6 priorities is housing, transportation, and economic stability. Again, people don't live in a vacuum, and we really need to come together and strategize how to have influence and remedy and go further upstream regarding these conditions that really impact, preventable disease. So one way we do that is in my office, within the Division of Social Epidemiology, they for many years have created what is called the Virginia Health Opportunity Index. the latest version of the index. The data is ready to rock and roll. I had the acting division director, he created this graphic. We, in the midst of COVID, ended up partnering with another entity we usually don't partner with, and we're currently working with them to make the site and the visuals a little more user-friendly. It skews a little more research-focused. But the bottom line is, by census tract, these are the areas in Virginia, and we categorize very low health opportunity to very high health opportunity. Essentially, the Health Opportunity Index is a composite measure of 14 indices that reflect a broad array of social determinants of health. So we're talking educational attainment, housing and transportation affordability, incarceration, job participation, air quality, household material deprivation index, all of these indices. And what that means is you're going down to the census tract level, because oftentimes, having data at the county level is great, but it sometimes obscures more granular data. What we say at the State Health Department at Central Office is, for instance, we know Loudoun County is known as the wealthiest county in Virginia. However, that's not to say that there aren't pockets within the county where there's communities that are not so much seeing that wealth or enjoying, the wonderful health outcomes that can occur when you are at a very high income level. And so it's highly critical to understand where those areas are. And again, these types of, it's not a ranking, but in terms of an assessment, it's not to shame communities, it's to highlight opportunities and where maybe investments are most needed. There's always opportunities for improvement where we can do better for the citizens of the Commonwealth. And so why do indices like this matter? Well, this is a chart in terms of the difference in life expectancy between very low HOI census tracts versus very high HOI census tracts. And here you can see, a difference between 76.5 years and then 81.3. That's a big difference. And when you talk about in, some areas where, census tracts are neighboring each other, and to have this difference in life expectancy, we as a community, we as advocates need to think about, are we okay with that? Are we okay with those differences? And data is only as powerful as what you do with it. My final slide, I wanted to share with you what the Ripple Foundation has determined the vital conditions for health and well-being. I really love this chart. The Ripple Foundation, they are a private foundation. They were originally established in 1953, focusing on cancer, heart disease, the health of women and the elderly, and hospital system maintenance. And over time, as time evolved, realizing that we need to go further upstream. In order to impact these areas that our founders care about, we really have to focus on these vital conditions. And as you can see, humane housing, which is adequate space per person, safe structures, affordable costs, diverse neighborhoods, without gentrification, segregation, concentrated poverty, close to school, work, food, recreation, and nature, that is a key part of the vital conditions. In essence, these are the conditions that are, or rather, the properties of places and institutions that all people need for health and well-being. And by highlighting these and focusing investments on these, we can invest in the conditions that are necessary to creating a thriving future for all. So that's where I'll leave it, and I'm happy to pass it on to the next speaker.
All right. Good morning, everyone. Let's see if I can make this work. Probably need help. There we go. Okay. Well, I don't know. How do I get it out of there? You want to?
I mean, I was struggling earlier too. So I'm sure my
Okay,
person- There you go.
there we go. You guys got a sneak peek at all 3 of my slides. I can't surprise you. And you won't be surprised by Teresa's either, because she stole a third of my slides. I'm Dr. Theron Steiner at Fredericksburg Christian Health Center. The social determinants of health, such as safe and affordable housing, they influence up to 80% of healthcare outcomes. And so that means the medical care that I provide, or that's provided in a doctor's office or in a hospital, only contributes to about 10 or 20% of someone's overall health and well-being. And so, I run a nonprofit family medicine clinic. 40% of our services are charity care. And I find that reality, that my visit with each patient has such a small influence on their health, that's discouraging for me. I would like to believe that I'm an outlier because I spend extra time with my patients, and our clinic tries to address social determinants of health. So, maybe we have 30 or 40% of an influence. But that's, still much less that physicians would like to believe that we actually have on our patients' health. But I think those statistics are actually true, and I see that. I can run tests, I can make a diagnosis, perform a procedure, prescribe a medication, and it often is not going to result in a dramatic improvement in that patient's health if they're unable to change their circumstances or they're unable to follow my treatment plan. That patient is not going to benefit from a medicine I give them if they can't afford it because they can't pay their rent and also pay for the medicine. I see patients who have persistent respiratory problems. I'm glad that you mentioned asthma, because that's a really common one that, I can prescribe someone inhalers all day long, but if they live in an unclean or crowded living space, if they share living space with smokers, or if you have multiple people sharing a bedroom, requiring some people to sleep on the floor, and they're in a house that's never cleaned and they're inhaling dust all the time, my inhaler is not going to do a whole lot for them. I see patients who can't utilize stairs in their home, and they don't have the option of being in a house without stairs. Patients who can't bathe because they physically can't get in or out of the tub. Patients falling and breaking bones due to clutter and other fall hazards in the home. Patients who don't exercise because it's unsafe to walk in their neighborhood or along their country road. But that intersection of health and housing, I think, is most apparent in the unhoused. So people experiencing homelessness, they regularly get wounds, skin infections, as well as respiratory infections, minor injuries from living outdoors. They are seeking care at the ER for problems that could be treated by a primary care physician, PCP. They don't know how to navigate the healthcare system in order to get a PCP, let alone stay in one place long enough to even establish a relationship with a family physician. Their lack of housing creates a nomadism, and the person is not staying in the same place long enough to form healthcare relationships or any relationships. And we just recently, declared social isolation a new pandemic, right, or epidemic, potentially worse than smoking for our health. Lack of housing also creates a survivalist mindset, and so there's no room to think about regular checkups and disease prevention. And so it's another reason that the unhoused person will never establish a relationship with a PCP. The ER is then getting overutilized for these non-urgent medical and psychiatric services, and the ER also becomes a place to be warm during the winter months. So in unhoused persons, you have diseases going unmanaged until the heart attack or the stroke happens. or that wound gets so bad that it needs to be amputated, or there's a mental health emergency, or their underlying cancer has spread to the point that they cannot take care of themselves anymore. And so now the hospital is taking care of this homeless patient who has a devastating medical condition that could have been prevented. And then those patients are admitted to the hospital, and they get discharged right back to the streets. And of course, they're, discharged from the hospital with medicines, and they're told to follow up with different specialists. Maybe they're told to follow up with a PCP. But that patient experiencing homelessness has no clue how to navigate the healthcare system. There are very few, if any, specialists that are going to see them if they don't have insurance, or even if they have Medicaid. Now that we've expanded Medicaid, there's still a lack of access, and so follow-up never occurs. That homeless patient has no clue on how to take their medication. They don't know what it's for, so they just kind of take it at random intervals until they run out of it, or the medicine was ruined due to unsafe or improper storage, or often it's stolen. There's no concept of refilling that medicine once it's gone, and so the patient's back in the ER again. So many of the patients that I take care of through Health Bridge with Micah Ministries, many of these unhoused neighbors, they were going to the ER and being admitted to the hospital often, some of them on a monthly basis, sometimes even multiple times a month, until we started providing primary care for them through Micah Ministries. So Fredericksburg Christian Health Center, we've always kind of been a place in the community where our partners, such as Micah or the Brisbane Center or Transitions for You, and our other community partners, they knew that they could bring their patients to us to receive comprehensive and compassionate care. But the reality is that most of the unhoused population is never going to set foot in a doctor's office for a variety of reasons. So about 18 months ago, we decided to start bringing the care to them through our partnership with Micah. In this way, we could have a greater impact on that patient's health and try to eliminate not only a barrier to care, but also the effects of the social determinant of lack of housing. So the housing situation of these patients has not changed, but we can address some of the ways that that lack of housing would impact their health. So those who are unhoused generally do not receive preventative medical services or chronic disease management. They generally do not have access to the healthcare system outside of the ER. But now, those who are unhoused in downtown Fredericksburg do have a PCP. And I didn't advance one of my slides. Sorry. So that's just talking about the social determinants of health and how little impact I have in my doctor's office compared to everything else going on in the patient's life. And the pictures on the left is what the experience typically is of someone experiencing homelessness and the healthcare system. And on the right, you see me visiting with patient, guy on the top is a patient who is receiving housing through Micah, would otherwise be on the streets, and then me performing an exam in the clothes pantry, I guess we call it, the closet, the clothes closet at the Micah Day Center. So there you have it.
Good morning. I feel like I can't see you. You've already heard today about how housing and healthcare are linked, but let me introduce you a couple of other concepts from the current literature. Homeless persons are more likely to become ill, have greater hospitalization rates, and are more likely to die at a younger age than the general population. The average lifespan for a homeless person is between 42 and 52 years old. I was recently told for the unhoused, 50 is like 75 for you and I. And cited from a California study found that in 1990, 11% of the unhoused were 50 years old or older, but more recently, that number is 48% of the unhoused were 50 or older. At the other end of the age spectrum, homeless children are much sicker and have more academic and behavioral problems. Homeless persons tend to have the same medical problems as the general population: diabetes, high blood pressure, and high cholesterol. They differ from the general population, however, in that they are experiencing long-term exposure to disease agents, overcrowding, unsanitary conditions, poor nutrition, sleep deprivation, violence, physical and emotional trauma, sexual abuse, and weather extremes. In addition to physical illness, many people experience traumas on the streets or in shelters, which has long-standing adverse impacts on psychological well-being. These and other challenges can result in persistently high healthcare expenditures due to emergency department and inpatient hospital use. Limited education, mental illness, substance abuse, and distrust can affect their ability to respond appropriately to these adverse conditions and manage their medical problems. Based on these factors, homeless persons tend to present with advanced disease, and the approach to therapy is different depending on each person's situation. Literature suggests that an integrated multidisciplinary health team with an outreach focus, along with involvement of local and state agencies, seems best suited to address the components needed to ensure quality of care and help make these patients more self-sufficient and to help them succeed. Family physicians are well suited to manage the needs of the homeless patient, provide continuity of care, and lead these multidisciplinary teams. So let me tell you a little bit about what we're doing at Micah Ecumenical Ministries in Fredericksburg. For those of you that don't know about us, Micah Ecumenical Ministries is a nonprofit organization that has been addressing the needs of the homeless population since 2005. But before that, Micah's founding congregations were involved in caring for the community of homeless population since the late 1980s. At Micah, we are taking this team approach to healthcare with our neighbors that the literature supports. In April of 2022, as Dr. Steiner mentioned, we started a program called Health Bridge, where we have partnered with him to bring healthcare to our neighbors where they are, where they already come to receive services, a place that they already know and are most comfortable. This occurs at our hospitality center, our street drop-in program, and sometimes right in their own homes, where they have obtained permanent housing. We've expanded that program now to include 2 family physicians and an LCSW to bring needed primary care and mental health services to them. Every Thursday, Dr. Steiner and Dr. Crawford come to Micah to see our neighbors for basic and unaddressed health care services, and we help bridge them to community resources for their health care. The rest of the team at Micah that we've built to support this health program includes a medical social worker, a housing skills coordinator, a housing care coordinators, and myself, an occupational therapist, as program coordinator. The first visit, an outreach visit, will most likely be the first contact with the homeless patient. During the initial visit, the physician and staff focuses on demonstrating genuine interest, empathy, and respect in a warm, non-threatening, non-judgmental environment. I have had the immense pleasure of watching Dr. Steiner and Dr. Crawford do just this as they begin to build trust and relationships with our neighbors before we even address their medical or mental health needs. This approach greatly increases the odds that they will return to see us and follow up with the recommendations made for their health care. Once this trust and rapport is established, visits then focus on discussing the patient's more challenging social, medical, and mental health problems, and even end-of-life issues. The goal is to address symptomatic problems first, which can be treated with simple guidance and will have an impact on their daily life for a long time. After completing the initial assessment, our physicians take into account the logistical complexities, developing an appropriate treatment plan for these unique patients. Many referrals, scheduling, follow-up appointments, making referrals, scheduling follow-up appointments, and monitoring lab results and response to therapy are challenging because of the lack of dependable communication and transportation. The HealthBridge staff acts as the patient advocate and, along with our care coordinators, help the neighbor with the follow-up needed. Identifying the homeless patient and those persons at risk is our priority at MICA. So another program that we offer is our health screening program to help us identify neighbors who present with already advanced disease or neighbors who are at great risk for disease. This program is a partnership that provides a clinical rotation for 2 local community college nursing programs. Every Tuesday, our hospitality center, again, that familiar place, serves as the setting for these health screenings, where nursing students take a full set of vitals, gather basic health information, and screen for depression, anxiety, and substance use disorders. This is often the first step in really being seen, this kind of seeing, as well as being seen in a health context for screening for health issues for a neighbor who hasn't been addressing their health needs or for someone who hasn't had health care for a long time. We are currently expanding this program to our neighbors in our newest program called Hesed House. And lastly, another program we started at MICA is our home care program, where we offer skills training and personal care for those neighbors who are having trouble maintaining their home or taking care of themselves. With the additional help from a personal care aide, we have been able to improve the safety in the home as well as the follow-up on medical needs. We are seeing improved medication management, improved home safety, and decreased isolation, again mentioned this morning, with those neighbors in that program. In addition, we've worked to establish community partnerships with agencies and organizations, including some of you here today, who work directly with us to reach the goals of independent, safe, healthy, and productive living for our neighbors. In conclusion, studies cited in several literature currently support the idea that housing improves health outcomes and decreases health care costs. At MICA, with the programs that we've implemented, we are improving health access, removing barriers to health care, improving health awareness, and improving health outcomes with the homeless and housed neighbors that we serve. As we look to the future, we are already planning to include health care programs in our next project, Jeremiah Community, a village of homes being built for our neighbors. Insufficient personal income and the lack of affordable housing are the major reasons for homelessness. Complex, advanced medical problems and psychiatric illnesses exacerbated by drug and alcohol abuse, in combination with the economic and social issues such as the lack of housing and proper transportation, make this subset of the population a unique challenge for the healthcare system, local communities, and government. The evidence of the relationship between housing and health is complex but compelling. The healthcare sector, businesses, community-based organizations, foundations, and government, all of whom are represented here today, I'm very proud to see, have unique roles to play in improving housing conditions in the United States. Selected housing interventions for low-income people have been found to improve outcomes and decrease healthcare costs. As a result, many healthcare systems, payers, and government entities are seeking to better understand the totality of the health and housing literature to determine where they might intervene effectively. So today, I thank you for your participation in this Regional Housing Summit. I'll turn the session back over to our moderators.
And we're now going to take some questions. So if you guys want to raise your hands, I'll come to you.
Great morning, everyone. Thank you for an amazing presentation from each of you. My name is Kelly Evans. I work for the Institute for Public Health Innovation, where I work with community health workers across the state of Virginia. And specifically, I want to ask Dr. Steiner this first question, because in opening your center, what were your thoughts centered around, as a physician, not having contact of going out into the community. And now pretty much, how do you see yourself as a voice to speak to other physicians who may be looking to enter into that space? Because I know there's a difference between the provider I may see, and then they may not be attached to the community. So how can you encourage other physicians to really look at the work and really think about serving the community as it relates to the homeless population?
So I heard a few different questions, and the last few that I heard, I think, kind of lumped together in terms of how can I encourage others, or kind of how can you get more physician buy-in in kind of doing what we're doing. I missed the first part, but you want me to answer the second one?
You can answer the second one.
Okay. So I think it's hard because, like when I started my presentation, it's hard to convince people that what you're doing isn't making the difference that you think it is, right? And physicians and healthcare professionals in general, like we've had a lot of education, and there's a perceived expertise and status and all these things, and then to like think of, hey, the solution to the person's problem isn't me. You have to be able to accept that first and be in a position to do that, and also have a willingness to like not just go along with the system, and kind of do what you've always been doing. You have to be willing to take some significant financial cuts, because our healthcare system is not set up to take care of that group of people in that way and in non-traditional ways. So, there's a lot of factors that go into it. And at the end of the day, the person has to have the heart to really want to take care of that group of people and have a willingness to make sacrifices in order to do so. And then they need to be in a place where there's an opportunity to do that. And, certainly if there's other people in Fredericksburg that, have that heart, like we can certainly make room for them at Fredericksburg Christian Health Center. And there's other opportunities in town too. We're fortunate enough that we actually have a few safety net clinics. But it's challenging because you have to go against the grain. And even for us, like I said, before we'd always accept people in, and that was kind of good enough. And it wasn't really until Medicaid expanded that we stepped back as an organization and said, okay, our mission statement says that we are going to, provide high quality care to those who can't afford it or don't have access to it. And well, what does that mean now? The population has shifted. It's, before it was all uninsured. And so we said, all right, well, do we just say Medicaid patients, they still lack access to care, they still can't afford care? We're gonna, be happy that we're actually getting paid, by Medicaid now, even though it's not much, and just go on doing business as usual? Or, all right, who is it that still needs our help? And so for us as an organization, and the shift is still happening, and it's slow and it's hard, and you have to rechange your workflow, you have to rechange your funding, you have to do all these things, and to be quite frank, like if you're not a nonprofit, that's going to be really hard to do. I have the luxury that I can ask for donations and put on a fundraising event or write grants or whatever, but if you're in a for-profit business and you've got this business model and you're going to change it, they're going to take some pretty significant financial losses in order to do that. So I think first you have to have the heart for it, to really want to make that change and really want to help people. Like that has to be your main priority, because if it's just a side idea or, oh, that would be nice, it's just not going to happen.
Hello, my name is Meredith Keppel. I work for the George Washington Regional Commission as the environmental planner. So I come to this conversation with the lens of environmental planning. And one of the things that I know I've talked to Ellen and Allison about before is our urban heat island study. And one of the things that we did in 2022 was found that there was a 17-degree temperature difference in our region. So that is the hottest spot in the region is in Garrisonville, Stafford, and it's 17 degrees hotter than the local forest land. So that's significant. And our average urban heat island is 3.6 degrees Fahrenheit hotter than the surrounding area. So that's significant. For comparison, some of the hottest areas for urban heat island are in Chicago, and they're about 8 degrees. So we're getting up there. We're getting close. And about half of Chicagoans live in urban heat islands. We're doing some analysis on the city of Fredericksburg to see how much, but it seems like we're about on par. About half of our residents live in urban heat islands. So that's significant. One of the things that I want to ask about is how do we, as we advocate for green infrastructure, also include that conversation around health equity? Because I think that's something that's lost. It seems like it's two different camps. You know, there's the people talking about green infrastructure as it addresses stormwater and heat, and then there's the people talking about health outcomes. And I want to integrate those conversations. So how do we bridge that gap?
I think that's for you.
Yeah, that sounds like a me question, and I appreciate that. You know, one thing that immediately pops in my mind is as we experience, you know, hotter temperatures and more extreme weather events, you know, hot temperatures exacerbate the risk of, you know, cardiac instances, stress, all of that. So, you know, that's one way I think of integrating that conversation. You know, it's a tough conversation, but it's absolutely necessary. You know, I think when I think of green infrastructure, like that, you know, that ties into livability, right? And at the end of the day, I think health equity is making sure that everyone, no matter income, race, ethnicity, religion, ability, geography, that you have the opportunity to reach optimal health. And so I think having these conversations, you know, making sure, and I say this a lot in other types of infrastructure conversations, like walking paths and bike lanes and trails, and making sure that there is a connection and getting community input and buy-in so that communities don't feel like, oh, this is being built for, you know, the people who are going to move in these fancy condos that are going to be next to this trail. You know, do you know what I mean? And ensuring that it's for everyone. And so infrastructure, green infrastructure, we've come to a point where I feel like if we're really going to move the needle on, you know, the risk of experiencing these adverse climate events and all that comes with that, it's no longer like nice to have, it's must have, so that we're building, you know, sustainable communities. And so I think taking into account, ensuring that it's not just for, you know, the 1%ers, that, you know, if there's stormwater management, if there's, absorbable payment, pavement, you know, all of these things, it needs to be for everyone to ensure that bit of equity. You know, honestly, the other thing, and you kind of alluded to this in terms of there is a tie between the heat, and it came out the last couple of years, like the heat island effect in urban areas and the redlining maps of history. I mean, that is a fact, and that can't, you know, to people who say, oh, you know, that was so long ago, yada, 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 it's like, no, that had a tremendous impact because there was federal policy for decades that influenced who is able to purchase a house, who is able to live where. And at the end of the day, When we talk about the social determinants of health, in this country, most people's economic assets are tied into home ownership. That is how they build wealth and pass it on to their family. And if you don't have that opportunity, you are not passing that wealth on to your family. And that impacts the safety net. If I know, that if I get in a major crunch, my parents, they might be able to help me out. And we've come a long way. My, highest level of education for either my grandparents, 6th grade level. I had one grandfather come over at the age of 16 from Mexico. But we're lucky. And so it's like using that privilege to advocate and do the work that I do. But I kind of rambled on, but I don't know if I answered your question. But there are, I would say, in the European public health space, and the Lancet in particular, and if you want to reach out to me, the Europeans do a far better job of tying climate change and global health and economic drivers than the US does, to be frank.
My name is Erica Dutcher, and I'm with Central Virginia Housing, and this is for Dr. Steiner. I know you were speaking a lot about how you've had to make, as a clinic and as a business plan, some real sacrifices in order to prioritize the work that you guys are doing, and I know all of us as a community see this as such a gift. But in that light, what is your capacity to take on additional clients, and what is your capacity to continue the work that you guys are doing?
Right. Is this on? You guys can hear me? So in terms of taking on additional clients, it's very low right now. We are taking some new patients, but like over this past year, we had lost a physician, and partly just because of, again, kind of the work we do is different, and it can affect kind of burnout and other challenges in different ways. But so like right now we're not taking any new Medicare patients and probably won't until we hire another physician, and we're getting kind of close to the point of not accepting new patients outside of our community partners. So unless it's someone from Micah or Mary Shelter or Zoe Freedom Center or wherever, saying, hey, we've got a patient for you, we're getting close to that level. We started a behavioral health program this year with a licensed counselor, and it's been just about 4 months now, and literally just this past week we had to make that decision with her and say we can't take any more referrals outside the community except from our community partners, because she's getting booked out weeks out, and people are waiting too long for follow-up. So yeah, it is challenging. We're constantly trying to add services, trying to hire more people. And it's hard too, because some of our model is a bit of a Robin Hood model where the profit from our insured patients helps offset the cost. But so it's kind of like, well, if we bring in more insured patients, then, we have more money to do charity work, but we need to, we need the staff to do it. And in this area, it's really competitive in the healthcare sector. And, once that VA hospital opens also, it's like, oh my gosh. So we're already kind of thinking ahead of like, how is that going to impact what we do? And do we need to like rethink of our model, in fact, in light of some of those realities?
So an hour goes fast. We are actually already at time. Did you have one last comment? Do we want to do one more question?
Yeah, please.
Okay.
Yeah, good morning. Yeah, my name is John. I work for the Community Service Board at the Rappahannock Regional Jail. I work with male and female offenders. Quickly with the green infrastructuring, climate change, on the micro level, that's done with house plants. You might be in an apartment, 2-bedroom apartment or to a mansion, but just starting right there with house plants, that's a green infrastructure, especially with children with ADHD, even behavioral health. There's peer-reviewed articles that just spending time in the green, house plants, impacts that. Planting trees, getting involved with conservation, like Friends of Rappahannock, planting trees, taking, boats out, restoring oyster beds. Yes, housing is important, but also getting the children, everybody outside the housing. Just planting a vegetable garden, having fresh herbs in the house, all that is, green infrastructure. That's really emphasized with my clients at the jail. When they get out there, try to get in volunteer activities with, like Virginia Tech, with the Cooperative Extension Service. It might have a few hens laying eggs, having a beekeeping, with honey production. All that is going to help bring with the temperature down, and also with improve mental health.
Awesome. So it looks like our session is over. Just as an FYI for everyone, they're going to be moving the partition back over, so opening the room back up. Lunch is getting prepared, so they will be serving by table. So if you could find a table, just chill out for a second, and then they'll call your table up, and then lunch will be served to you. All right?